years also. This was kind of unfortunate, as Bob said, Dr. Constantine said, we write these guidelines to prescribe medicines in psychiatry, and we hope that they'll be useful. And they're in the system so that you can access the guidelines, and there are only 12 times that people access the guidelines. So that's unfortunate. There is drug information monograms put in there with side effects and those kinds of things, and those were looked at 131 times, so that's pretty good. But we wish the guidelines had been more perused. We have, since we started this, added 3 more doctors to the original 5. We're up to 8. We've tried to identify the needed improvements in reporting and elimination of duplication of work. And we know this is going to happen, so our push is to get every doctor involved, because I think that has to happen. And we're going to continue in the pilot through December of '08 and finish the year. And with that, I'll turn it over to Dr. Sohas.
Okay, good afternoon. Hi. If you notice, I have a really long name. It's just shortened. I'm from that Fort Lauderdale, Miami area, actually Fort Lauderdale, and Henderson Mental Health Center. We are a pretty large, I believe the largest in the South Florida area. And we range anywhere from, say, 16 to 20,000 unduplicated patients, of which about a third, about 5,000 are kids. So we have a very large patient population. We have 15 psychiatrists, 12 are full-time, and 3 are part-time. So, and we have a great CEO who is also always, backing us up with all quality improvement measures. Unfortunately, we don't have EMR, so we are basically utilizing EmpowerX and the little PDAs. We actually got most of our doctors to have one of those devices, but a lot of them send them back. They did not want to, be responsible for, not losing them. And we have a couple of psychiatrists who've been with Henderson for over 35 years. So we have that the young docs are more involved. They're more, electronically comfortable. So at this point, I would say about 50% of our doctors have those devices and are using them. And we are utilizing the e-prescribing with our handheld devices, not the desktop version, because the desktop seems to be more limited and also very slow. And our computer systems are not, we don't have the real fast, high-speed. And again, a lot of the other programs I think, are not as available on the desktop as it is on the handheld. So we are using exclusively the handheld. So to give you a little overview, what was the reason we decided to embark on this project? The objectives of getting involved was, of course, to improve clinician access to pharmacy information and e-prescribing tools. Now, there are 2 aspects. One is use of the PDA for other purposes, which we have been doing, just like you mentioned. Only a third, I think, was your data showing using it for e-prescribing, but other purposes such as getting patient histories, making sure that there are no other prescribers, there's no duplication. So that for accessing that data, we are using that more than for the e-prescribing. To demonstrate the efficacy of e-prescribing, because there are a lot of advantages, and to identify barriers that could be preventing the widespread implementation of e-prescribing, because there are barriers and there are some problems that we do encounter, and I'll be addressing some of them that we have encountered. So what were the advantages that we thought would be great to get started? Prevention of prescription errors caused by illegible handwriting, look-alike or sound-alike drugs, etc. We have problems with our physicians, with their handwriting. We have sent some of our physicians to handwriting classes. So, and I have to say that one physician turned out to be a star. He really has improved. But we have another one still working on it, and you know, it can be a problem. It's how do you change that? Time constraints becomes an issue because everybody is writing fast and you know, have very little time to see the patient, write a prescription. We are not EMR, so we are going to hopefully become electronic medical records in about 2 to 3 years. That's our goal and our vision. But at this point, we are not, and we do have physicians with bad handwritings. And so prescriptions, if you write illegibly, that's a huge liability, and it's for the patient and for the agency, and it's a problem. So e-prescribing is great for that. Ability to view information on drug-drug interactions and critical drug alerts. Again, fortunately, even if you don't e-prescribe, if you're using the Medicaid, you know, devices that we are able to have, using that, we can access that information. Having access to information on formulary availability, again, a lot of time can be saved if we are prescribing what's on the formulary rather than, you know, doing prior authorizations and photocopying, you know, information to fax over and all that kind of stuff. So if we start it right the first time, we don't have to waste time. Increasing communication between physician and pharmacy, and have specific pharmacy information. That seems to be really great for medications such as the benzos and, you know, any of that where there's potential for abuse, and being able to send prescriptions to a pharmacy, so that helps a lot. And of course, increasing work efficiency, although sometimes the physicians have complained that it really slows them down. Having information on the patient's complete medication history, another advantage. Avoiding unnecessary duplicative medications, reducing fraud, abuse, misuse of medications, avoiding incorrect dosing. That's also another advantage. Although sometimes we have to really be careful what we are clicking. You know, we have to make sure that before we send it, we view whatever is the final product, you know, final information. So that's important. Expediting refills. It's great. Some patients love it because it's already at the pharmacy. They don't have to make a trip. Especially I've had patients complain about gas prices. You know, you have to go to the pharmacy, drop it off, and they say it'll take 2 hours, and they come back home, and they go back to pick it up. This way, it's already waiting, and it's ready. They can just go pick it up. So they love that. And improving convenience to patients, of course. So Henderson Mental Health Center, I have a medical staff meeting every month, and what we do is we meet, we talk, we discuss issues, you know, quality improvement, any policy changes, all of that we discuss once a month, and we're pretty spread out. We do not have a pharmacy of our own, so that's, you know, a disadvantage. We are spread out, and this way all the physicians and the nursing staff get to meet once a month. We are able to, you know, kind of brainstorm any issues or problems that may come up. And so that is really the best venue for us to introduce any new ideas or projects or stimulate dialogue. And so that's what we did. Basically, we introduced the project at the medical staff meeting. And I did not want to set them up for failure, so decided perhaps it's best to kind of pick physicians that have a comfort level with electronic stuff. And especially, I am not going to pick somebody who had a PDA and sent it back. So it's like, you know, come on. So that did not make any sense. And so fortunately, I had a couple of young physicians. Unfortunately, one of them who really, you know, just very aggressively started prescribing. He did wonderful for 3 months, and then he moved to California. So I was getting worried, oh my God, what am I going to do with my numbers? But by then the others picked up. So we picked physicians who already had some level of technology comfort. One of them I picked I thought would do great because he's an engineer. He's an engineer and went to med